Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Iran, and I hope all of you are well, and thank you so much for being with us during all the sessions on Hot Seat, and I hope that it has been full of information and data for all of you for improving your skills, for increasing your knowledge, and improving also your practice outcome. And I'm so happy to have a very dear friend, a great lecturer and a practitioner. Juan Mesquida is here with me today. Hello, Juan, and welcome to Hot Seat. Thank you, my friend, for accepting the invitation.
Hi, Omid. Thank you so much. I first want to express my gratitude. Omid, it was like a good day, a happy day when you called me to be part of your Hot Seat, and just looking at the lineup speakers you managed to get together. I feel honored. I may say probably amongst the youngest clinicians in that panel, as well as you. And for me, it's an absolute honor. You know, all I try to do here today with you guys is try to give a little piece of the knowledge I've been able to develop over the last years. Like I said, I'm a very young clinician. I still have a lot to learn, but I'm a very observant clinician as well. So I'm willing to share the observations that I believe on the mandibular incisor over the last few years. And then thanks again for your kind invitation.
Thank you, my friend. And as all of our audience know, over the past sessions and over the past season also, we tried to cover almost every aspect in implant dentistry, but some parts are missed, and today is one of them, because one of the most challenging areas that usually we can do implant dentistry is anterior mandible. And we have so many limitations in this area regarding the space, regarding the bony housing, the restorative part of it. And I think it's one of the interesting topics that Juan is going to talk about for us. And the topic that he will present today on Hot Seat is the failing, missing mandibular incisor, the ultimate surgical and restorative challenge. So I think it's very interesting topic, so I'm personally very excited about it. And before we start, I would like to have Juan's CV for all of you, and then I will shorten my speech. We'll go straight to the presentation, and at the end, we'll have a great discussion on the topic. Juan Mesquida has been involved in implant dentistry since graduating as a DDS in 2005. He was awarded a master's in implant dentistry at ESI Barcelona in 2007, and later in 2008 joined the graduate program in implant dentistry at Loma Linda University, where he graduated in 2011. During his implant specialty residency at Loma Linda University, he received the first prize for Best Research Presentation at the 2010 annual meeting of American Academy in Implant Dentistry in Boston, Massachusetts, and was awarded with the first prize in table clinic category in 2011 in Las Vegas, Nevada, something that never happened before in 30 years of Academy history. After completing his specialty degree in implant dentistry, he was appointed assistant professor by the program director at the implant department at Loma Linda University School of Dentistry. Dr. Mesquida lectures internationally on implant dentistry related topics and has published scientific articles in relevant peer-reviewed journals and has co-authored renowned dental implantology book. Once again, I'm so happy to welcome you, my friend. The platform is all yours, and I'm looking forward for your beautiful presentation. Please share your screen.
Thank you very much for your very nice presentation, Omid. I'm gonna go ahead now and share my screen. And first of all, and it's something I like to do every single time I start a presentation, I like to explain a little bit of where I come from. I'm more than that, try to show gratitude to the people who deserves it, the people that has helped me throughout this path. Like Dr. Moghaddas has said, I come from Loma Linda, where currently I'm assistant professor. And as of today, Dr. Jaime Lozada, as you can see on our left, is our program director. Dr. Joe Ken, our scientific director. Dr. Nick Planis and Dr. Aladdin are clinical directors, and together with Dr. Isvan Urban, which is our professor specialized in bone reconstructive procedures. Yeah. So like I said, for me, these are 5 keystones, 5 pillars where I have built all I know today. And I feel tremendously honored to be able to say that I'm part of their team. I still sometimes hit myself when I wake up and I realize that I'm working with such an amazing team of clinicians. So thanks to all of them, and thanks again to you, Omid, for the opportunity to be here with you. On an informal chat with Omid, one question he asked is like, your topic is very particular. You like to talk about something that we all find challenging, but yet we don't hear a lot about. There's not a lot of publications. We go to large meetings and we don't see podium speakers talking about the mandible. Yet we all know it's probably the hard challenge we can face, particularly with our aim is high-end aesthetic dentistry. Yeah, and we want to get a predictable and a high-level restorative results, essentially. So I want to start with this patient I didn't treat that long ago, a patient that got referred to me by a good friend, a general dentist. And he told me, Juan, I need you to help me here. I have a big problem. I have a big problem. While I was doing a retreatment on a mandibular incisor on this young lady, young, beautiful lady, I, by mistake, perforated the root, and I don't think I can repair that perforation. So I think we're gonna have to discuss an implant treatment with this lady, and I would like you to do the implant treatment for me. The first thing I looked at when I tried to analyze this patient and I tried to see how I can help this patient, I just go to the train of thought that I would naturally go when I deal with any restoration or implant-supported restoration in the anterior maxilla. But I applied, obviously, or I use it for the mandible because I have to build my castle, my treatment planning decision tree based on the knowledge I know. The knowledge I know now is telling me I should analyze bone morphology, characteristics, dimension. I should analyze the gingiva that I'm going to be dealing with, biotypes, phenotypes, if you prefer. I like to look at thickness because I have to conceal certain restorative materials. So I need to make sure that I can mask that dark restorative materials, that dark implant that will be underlying this very thin gingiva. I have to look at something that you, Omid, already mentioned. That's a key point here. Horizontal and vertical spacings, narrow, very tight spaces, hard with, even at a skill level, not easy. Then surgical technique, multiple techniques, immediate implant placement, early implant placement, better to extract, better to wait, better to place the implant simultaneously. Mandible is very different. Raising a flap in the mandible as compared to raising a flap in the maxilla has a very different effect, very different impact because of the dynamics, post-operative dynamics of the mandibular tissues. And then, what else is important? The restorative interface. The restorative interface. It's very easy to over-contour restorations in the mandible. How often have we seen implant-supported mandibular incisors that look a lot wider than any of their natural counterparts? All the time. All the time. And then again, we're dealing, like we said, with small horizontal spaces, reduced horizontal spaces. What that means is that we will not be able to utilize certain highly aesthetic materials. Why so? We'll talk about it, but essentially, mechanical resistance, correct? We have very, very little space. We want to make sure we use very strong materials. Yes? Are we going to be able to do that and provide good aesthetics at the same time? It will definitely be a challenge. So we'll discuss that. But going back to my patient, Elizabeth, and looking first about the approach in relation to bone. And bone is, for me, where I built my castle again. You know, that bone is actually, in my opinion, the most important part of the decision tree. You know, that's where I want to start. Now, when I look at this particular patient, my first question that comes to my mind, and then again, in relation to bone, is that what surgical technique am I going to use here? Obviously, obviously, and we could have argued, we have discussed this in 2008, 2009, whether immediate implant placement was a good therapy or not, and it was predictable or not. I think in 2020, there's very little to talk about. Yes, I think immediate implant placement is predictable. It provides easy results, low morbidity, high patient acceptance, and probably the best aesthetic outcome we can get with as compared to any other technique. But it has certain requirements that not every patient will actually have. Not every patient is a candidate for immediate implant placement. Now, if I can go ahead and do an immediate implant placement in this case, I am sure I'll be happy. I am sure the patient will be happy. Now, what options do I have? Early placement. Yes, maybe if placing an implant in this infected socket, yes, in this socket where the axis of the tooth and the axis of the bone is slightly divergent, an early implant placement, as described by both, like they mentioned, 6 to 8 weeks, and then go ahead and place an implant simultaneous to guide the bone regeneration. Are we gonna, by doing so, are we gonna get into a better situation as compared to if we were doing immediate implant placement? Sure, we'll talk about that too. And how about delayed placement, classic protocols? Maybe for the mandible, the best type of protocol. We'll discuss a little more about that. But let's go back to immediate implant placement. Like I said, if I can place an immediate implant, in a fresh extraction socket, that will be always my first choice. What do I need to? What do we need, or what are we looking for in this socket, in this alveolus, in order for us to place an immediate implant placement? Oh, since 1994, you want at least 4 to 5 millimeters of apical bone, apical to the apex of the tooth, to make sure you can stabilize, you can get the primary stability that you need in order to place an implant predictably, and more importantly, to load it. Because immediate implant placement is particularly predictable when it gets to aesthetics, when it's associated with provisionalization, correct? Maybe we don't want to take the risk when we have less experience to have to place an immediate implant if we don't want to provisionalize, because the placement will consistently be more difficult. So it's important to keep that in mind. We want to get that 4 to 5 millimeters of apical bone for primary stability, and we want to make sure that we can provisionalize that immediate implants. Yes, that's something, like I said, that we know from plenty of evidence that has been developed in the maxilla, in the upper jaw. What else are we looking for here? We want to make sure that if we have to stabilize that implant, those 4 to 5 millimeters apical to the bone, apical to the apex of the tooth to be extracted, we're not going to invade any anatomical structure where we can end up having a problem. Let's say sublingual areas in this particular scenario, correct? You know, in the floor of the mouth, there is a lot of structure that actually we can get in trouble if we invade. So that's an area that we particularly need to keep an eye on. Then we know, and myself with one of my most beloved teachers, my professor, my friend, Joseph Kahn, we published a paper in 2011 proving that if you were able to leave a gap of around 2 millimeters from the outer contour of the implant to the internal aspect of the buccal plate, that gingiva and bone would be stable over time, that it was paramount, it was key to leave some space between the implant and the buccal plate, and either graft it with bone substitutes or do more modern techniques such as socket shield, for instance, a fantastic technique. Now, we'll talk a little bit about this in the mandible. Socket shield in the mandible, not so easy, not so easy. Now, how about a minimum primary stability? Again, we discussed that, and you know is essential for success when provisionalized. Now, let's look at this. First of all, are we predictably able to get 4 to 5 millimeters of apical bone in the mandibular incisor area for primary stability? Well, if you look at this particular case I'm showing you here, this is just a random CT scan I used from one of my patients, fully dented. full set of mandibular incisors, nothing failing. I just look at it and say, can I do an immediate implant placement? Can I get predictably 4 to 5 millimeters of apical bone? Absolutely, absolutely. No problem at all, which is relatively easy to find as well in the maxilla. Now, it's every single case like the one I just showed you. Now let's go back to the patient I introduced at the very beginning of the lecture, and let's compare these two CT scans. Completely different story. A completely different story. It is very important. It is paramount, like I said, to make sure that you get that 4 to 5 millimeters of apical bone in relation to the root tip of the tooth to be extracted. We need that. But there is a factor that is so much more important. We need this implant to be restoratively driven. As you can see in your right-hand side, in order for me to achieve that 4 or 5 millimeters or engage that 4 or 5 millimeters of apical bone, I have to place my implant either off axis or push it so buccally to the point that I cannot get that 2 millimeters of buccal space that I would need in order for that gingiva to stabilize over time. Then that is an issue. And I encountered this issue with a lot of patients dealing in the mandible. Now, here is the thing. What can we do in this kind of situations? Can we go ahead and move the implant more lingually? Well, we need, and that's something that you will observe very, very often when it gets to implants in the mandible, lingual over contouring of immediate implants. Why so? Because an excessive movement of the implant towards the lingual side that ends up rendering an over-contour restoration at the lingual aspect that very often ends up developing mucogingival issues because of the movement of the floor of the mouth. We have all seen these situations. We have all of us seen them. So not so easy. We cannot afford to move these implants that much lingually. We cannot. We don't want to be over-contouring mandibular restoration. Now, can we change the angle? One may say, hey, Juan, Dr. Mesquida, please, you can angulate this implant more actually follow the long axis of the tooth. The problem here, and it's not my opinion, in a study published here in 2016, not very quoted. Why is that? Because it's the mandible. Not so much people like reading about the mandible these days. We don't read as much. We like to read about the maxilla. But what this group of articles tell us is something very interesting. The findings that I observed in this particular patient, having a tooth with a very different axis than the basal bone when we want to anchor the implant, actually this is not rare at all. These articles tell us, these authors, that generally, as an average, the difference, the angle that we will find between the long axis of the tooth and the long axis of the basal bone is around 140 degrees. Now, if you look at the line that I put on the right side of your screen, the angle between the vertical line and the arrow to the left is exactly 140 degrees. So as you can see, not so easy to be able to stabilize an implant without generating or creating a problem like the one I'm showing you here on this screen, a mandibular perforation. So now, is this case a good candidate for immediate implant placement? In my opinion, absolutely not. Absolutely not. Now, when I went into this process and had, like I said, only few patients here looking like this one, I said, okay, we have to ask ourselves, how often does this happen? How often am I going to counter that? Do I really need to treat the mandible in a different way? Do I have to change all I know, or I have to readapt all I know in order to be able to treat situations like that predictably? So what we do here with a group of director from Loma Linda and a group of friends that we have all similar research interests, we grabbed 200 CT scans. We measured 4 mandibular incisors of all of them. That means a total of 800 mandibular incisors. And we looked at a lot of things. This paper will be published soon. But essentially, in this particular lecture, I want to highlight 2 things, 2 findings we found in this particular study. First of all, going back to immediate implant placement literature. My friend, you remember, Omid, we want to have 2 millimeters of space in the buccal aspect of the implant to graft. We want to have at least 1 millimeter of palatal bone. Yeah, we really don't know actually if that works for the mandible, because like I said, 1 millimeter of palatal bone is covered by a thick, highly keratinized attached mucosa that we don't have in the mandible. So whether 1 millimeter in the mandible, in the lingual aspect, is enough or not, up to today, we still don't know. We still don't know. But what we do know is that we want to make sure we have some bone. And my reference today is around a millimeter. Now, if I want to leave 2 millimeters of buccal, a buccal gap, like I said, how often can I do that in the mandible? Reality is, the outer contour, the buccal lingual dimension of anterior incisors is for lateral incisors around 5.7 millimeters. And for central incisors is around 5.4. You guys do the numbers. How often are we able to perform an immediate implant placement flapless in the mandible? Not very often at all. Not very often at all. Now, another factor in immediate implant placement, we measured another variable here, what we called apex to fenestration, the distance we were to stand the long axis of the tooth, and how many millimeters will it take to perforate through the lingual aspect. Actually, on an average, lateral incisors tend to have more apical bone, around 7.5 millimeters, and those are the averages again. Now, central incisors tend to have they tend to have to be a bit more inclined and to have less apical bone to stabilize. Now, you may say, well, but you told us you need 4 to 5 millimeters of apical bone, but that's not a problem. Your averages are around 7.5 to 6.2. Sure, and that's okay, but we have to remember statistics. We have to remember that every average has a range. And within this range, what we found is that around 16% of the cases that we analyzed in this research were having under 5 millimeters of apical bone, apical to that apex of the tooth to be extracted. So around 16% of cases that in terms of vertical availability of bone would not be good candidates for immediate implant placement. Yeah, just something to keep in mind. Now, how about gingiva? How about gingiva? We all know this. I don't need to tell anyone that the anterior gingiva is the thinnest gingiva we can find in the entire oral cavity. You will all agree with me. But we don't really know the extent of its thickness because there is really not a lot of literature published on it. So if you look at all the articles since 1991 that have defined what biotypes are for us, what gingival thickness is, the people that has taught us all we know about biotypes, about phenotypes, and about gingival thickness and its impact on periodontal structures and on peri-implant tissue stability, again, it's all studied on the maxilla. We know nothing about the dynamics of the mandible. And now, if you look again, and you try to look at the patient I just showed you and compare maxilla versus mandible, you will realize that within the same patient, the variability, the keratinization, stippling, even thickness at a visual inspection is completely different in the upper jaw versus the lower jaw in this particular scenario, which is something that we encounter often. Now, a very good publication from 2015 looking precisely at that. Mandibular incisors and their gingiva, thickness, keratinization, and the thickness of the labial bone. What this group of authors tell us is that in general, around 55% of the cases that we're going to encounter in the mandible are going to be thin biotypes. Sorry, it's around close to 65% thin biotypes, okay? And around 35 thicker biotypes. So in general, we're going to be dealing with a lot more thin situations, which we know in general are less predictable, I would say, or harder to treat, let's say. They normally require more treatment. tissue augmentation, tissue modification, let's say. So that's a very, very important figure. But what is even more illustrative, what it really shows you the nature of this gingiva, is the fact that almost 20% of the cases of thin gingiva are associated with very, very little keratinization. They are not very attached or keratinized. As a matter of fact, the authors of this study tell us that on an average, the mandible biotype or the thickness of the gingiva in the mandible ranges around 0.5 millimeters. It's around 0.5 millimeter. But what is interesting again in this particular set of data is the fact is not the mean to me, is actually the range again. And these authors encountered a lot of patients with gingivas as thin as 0.2 millimeters. That is paper thin, essentially, and really a very skilled clinician is needed, is required in order to treat situations like those. You know, they're really, really thin situations. And now, and what is the relevance of this gingiva? In general, we assume from literature it is important, is the fact that the thickness of gingiva is important in terms of the tissue stability, to avoid recession, to avoid the tissue shrinkage, especially vertically over time. And that has been proven in multiple articles. You know, if we, in general, we deal with a thin biotype by thickening, let's say, through a connective tissue graft, through biomaterials that substitute connective tissue graft, we're going to be able to obtain a tissue that will behave similarly to a thick biotype, and we will be able to stabilize these tissues, these thin tissues. That's really not a problem. The other part here that is, or the other aim of increasing the thickness or the relevance of the intrinsic thickness is actually the visibility of the restorative material through the gingiva. And that's very important. You know, there is some publications by the group of Ronald Young and Christoph Hammerly that they tell us if the gum is not thick enough, if that buccal gingiva is not thick enough, there's no way you're going to be able to mask your restorative structure. Doesn't even matter whether it's white zirconia. If you don't have the sufficient thickness, you will have an aesthetic issue. So that becomes even more important in the mandible. Why is that? Because what I was mentioning at my second slide, the fact that because of the limited thickness of restorative material we use in anterior incisors, because they're narrow teeth, very often, we're forced to use metal in the sublingual portion and the subgingival portion. What that means is that thickness becomes even more important. So going back to my patient here, let's look at this situation one more time. We have extracted the tooth, thin biotype, mucogingival defects all over the place, and we know now that we're most likely dealing with a very thin biotype, and that we want to make sure that whenever we have to perform, let's say, bone graft procedures at a later stage, an implant placement, we want to make sure that that tissue is resistant to recession. So that's how I started this treatment, and that's how I start nowadays most of my mandibular incisors, even if it's just a single incisor. Stacking the deck in my favor, making sure I increase the thickness of the whole mandibular area in order so that this area could resist surgical insult easily. As you can see, coronally advanced flap with connective tissue graft. After 3 months checkup, tissues look completely different, much more keratinization. You can see much more stable, strong tissues to be able to do the surgical insult that we're gonna need to generate to place an implant and do the grafting we need to do in this specific area. Now, let's step back. And let's go to this other case. This is actually a very old case I have. You'll see the picture, the photography is very different, but it's when I realized, this is one of the first cases that made me realize what was the real problem with the vertical and horizontal spaces and the implant diameter in the mandible. This patient, an elder lady that actually flew into my practice from the Netherlands, and she came because referring dentist told her that I could do an implant for her in this area, that I like dealing with static cases, challenges. And the first thing that I saw in this particular case, when the patient came, my proposal to her, the way I wanted to tackle this situation was a bit mechanical for me. I was like, yeah, there's no problem. We have an issue here with the necks of these teeth to be restored. They're very narrow emergencies. This perio patient that has undergone multiple scaling and root plannings with the effect that you see on the thinning of the roots. This will be hard to recreate on an implant restoration. So why don't we go ahead and just put 6 veneers in this anterior teeth, has an implant in the middle, and put an implant crown? That's the first thing that came to my mind. Let's just restore this next. Let's just change the way that the adjacent teeth look to make my life easier when I restore the implant. Now the patient looked at me and she told me, well, I have been referred to you because they told me you were good at doing implant crowns, that you would be able to manage my case without a problem. And I came for you because I wanted 1 implant and 1 crown. I don't want to go home with 5 veneers or 6 veneers and an implant crown. I want you to place an implant for me, and I want that implant to look like the tooth right next to it. Say, all right, good to know a patient that knows what they want, yeah? So basically, I started looking into dimensions. I like it. I like when a patient challenges me. I like it. Say, okay, let's see. We cannot touch these adjacent teeth at all. Let's start doing some measurements here. If we look at this particular, generically, you can see that in the Wheeler's Dental Anatomy textbook. We know that mesiodistal space on central incisor, mandibular central incisors, is around 5 millimeters, okay? 5 millimeters. Now this one particularly here is rotated, so our space is a little bit more limited. But that's not the challenge for me. That's really not the challenge. The challenge, as you will see later, is to recreate the cervix, the neck of this teeth, prosthetically. And that has a lot to do with the implant I'm gonna select here. A lot, and we will discuss in that. On an average, and I'm not talking about this patient because you can see that the roots of these patients are particularly narrow, but on an average, just to give you a number here, a central incisor has a cervix, a neck of around 3.5 millimeters wide. Now, we talk about 5 millimeters, let's say in a standard central incisor, mesiodistal diameter, and around 3.5 of a neck dimension. If I have to select an implant based on what I was taught, let's say when I did my master's in Barcelona, at that time my knowledge about implants was more basic, and at that time they taught me essentially 4 things, and that's, you would agree with me, Omid, that's probably the first thing they teach you together with bone quality when you start with implants. Implant to tooth distance, implant to distance, and bone quality. That's the first 3 things you learn. So the first thing that we know from 1993, if you don't want to have problems getting too close to an adjacent teeth, you might as well leave around 1.5 to 2 millimeters of space. That's a publication from the group of Esposito in 1993. We have respected this article, what this article taught us for a long time. What we know as well is that in general, when we want to select an implant diameter, conventionally, classically, we've been told, you know, the closer the diameter of the implant in relation to the neck of the tooth, the better, because you're going to have a less abrupt emergence profile. What we have heard from classic perio literature for multiple times, over contours. Over contours were a problem in implant dentistry, but are they really? Then primary stability. Then again, that influences sometimes our diameter selection. It shouldn't be a primary decision factor, but sometimes it can be. We have more bone availability and we can't afford it because the size of the tooth. We like to place a wider implant, right? Because of mechanical resistance. And then implant diameter selection has an impact as well on the gingival and osseous architecture. The wider the implant, the less bone availability. So let's go back to this patient, Dutch patient, like I told you, that told me, I do not want to do any veneers. I just want you to take care of the tooth I am missing here. So I took a CT scan in this particular case, and I see a knife edge ridge, very narrow ridge. Mandibular area in general is an area that you know is highly corticalized. I mean, whenever I have to do GBRs, nowadays most of the time if I can afford, I do it simultaneous to implant placement if I can, but not as often in posterior mandible or in anterior mandible. In general, not as much in mandible. So in this case, like I said, it's a very old case. Did it a long time ago and wasn't so experienced. So, you know, I don't want to get myself in trouble here. I'm just going to go ahead and do, first of all, bone graft the area. And once the bone looks like how I want it to look, then I'm going to go ahead and put an implant in there. So topic on my lecture is not to guide the bone regeneration. I'm not going to go deep into that. That will be for another course. But what I go ahead and do is a simple guided bone regeneration with some shavings of bone from the same area mixed with some xenograft. And as you can see on the right hand side, just a few months after, things look already a lot better. The placing an implant, even though I don't have a lot of bone, I would say probably I fell shy on bone in this particular regeneration. I have enough to place an implant and to place it predictably. Now, I have seen that the CT scan is telling me that I have sufficient bone. Now it's time for me to do precisely that, to go ahead and select the implant I want to place in this particular patient. I'm going to ask my lab technician to do a diagnostic wax pattern, a wax up, and I'm going to measure the mesiodistal diameter or the available space that I have to go in there and place the fixture. And that is 5.5 millimeters. Now, the implant system that I normally use, these are the three options that I would use the most, okay? A 4.3 millimeters wide implant, a 3.5 for the 3.0. Now, if I listen to what Esposito told us in 1993, essentially, if I want to leave 1.5 to 2 millimeters, this patient is not a good candidate for implants, correct? If I want to leave that space, this is a problem. Now, good things is, and you all know, it's just trying to give you a little historic perspective on this, and things have evolved, you know, things have evolved quite a lot. And we know from my good friend, Pablo Galindo Moreno from Granada in Spain, we know that actually, whenever we reduce the diameter of the implant to be placed, we can actually get closer to the adjacent teeth. And that makes a lot of sense. You have to think of implants, prosthetic devices at the end of the day, that are vascularity, blood supply interrupters. If you place a big O wide implant close to a natural tooth, obviously that implant will interrupt blood supply to the tooth, therefore generating what we know, bone loss on the surface of the tooth that is in contact or close to the implant. So Pablo Galindo tells us here, essentially, if you reduce the implant diameter a lot, you're going to be able to get much closer to the adjacent teeth. How much closer? Actually, up to 0.8 millimeters if you use a 3.0 millimeter diameter. So that leaves me here with a dilemma, okay? Remember, we have 5.5 millimeters of available space. I can go ahead, obviously, I rule out the regular platform implant, yes, the 4.3 in this case, but I have two options. Now, you know, for a young student that has just graduated and is about to place his first implant in the mandible, there is no doubt about it. If he has to pick a 3 versus a 3.5, he will pick the 3.0. It's just more margin for error. You know, it's harder to do a mistake when the space is so limited. You know, we have a 5.5 space and we have to leave around a millimeter, 0.8 to 1 millimeter on the size. If I place 0.5, I have to be spot on. If I go with a 3.0, I have certain room for error. So that would be for a younger clinician. How about for a more experienced clinician? A person that has seen failure, that has seen implant fractures over time. How about those clinicians? Actually, I have had in implants fail. And experience is not that long. I had implants fracture. So nowadays, my train of thought will be to lean towards the 3.5 if I can, most of the time. And that if that is the only factor. Now, there is another factor, and I briefly mentioned it, which is aesthetics. Restorative, our restorative target. And for our restorative target, the mesiodistal diameter at contact point to contact point becomes irrelevant. It becomes irrelevant. That will not determine aesthetics. What will determine how successfully I can take care of this situation is how it will be my ability to recreate the neck of this tooth, a neck that is actually 3 millimeters wide. Now, going back to the relevance of biotype, and I keep developing into this in just a minute, it's important to know that this study briefly tells us that whenever gingiva is under 1.5 millimeters, we will not be able to conceal or to mask any restorative material. Is that important? And let's talk a bit about, again, restorative material, like we said, implant diameter, and aesthetics, and try to join them all together. So here is the thing. You will hear a lot of medical representatives, implant representatives, gonna come to your practice with an implant that has the same screw regardless of the diameter and the same exact connection. And that representative will tell you, doctor, I have a fantastic implant here. I have a fantastic implant. You know what? Your nurses are gonna be so happy. They can pick from the same box all the abutments, and they will never have to look which implant it is, which diameter it is. I have the best implant for you. And we clap. Yes, that is gonna take care of me. That's gonna take care of the mess that I have in my back office. Correct, Omid? We all there, we all there. So that's actually, let me explain you why. Premium implant systems all work this way. The head of the abutment screw diameter depends on the diameter of the implant itself. If I use the 4.3 millimeter implant in this particular case, the head of the screw will be 2.5 millimeters wide. If I use a 3.5, it will be 2.2 millimeters wide. And it will be the 3.0 implant, 3 millimeter wide implant, that will have the smallest head horizontally, abutment screw, around 1.8 millimeters. Why is that important? That is not important from a surgical standpoint, but that is extremely important from a restorative standpoint. Why is that? Because that lateral space from the diameter of the screw up to that diagnostic wax up that tells us that restoration needs to be 3 millimeters wide at the neck, that is the space that we're giving to our laboratory technician to recreate the aesthetics that we are looking for. So if I place a 3.5 millimeter implant, the screw is 2.2. If I leave my technician 0.4 millimeters laterally on each side of the screw, abutment screw, the only thing my technician is going to be able to do is either make a metal restoration, which is obviously not aesthetic, or over contour the restoration. Make a restoration that looks wider than the natural adjacent teeth. Now, if I go ahead and put a 3.0 with a narrower screw, it won't be easy for the technician. I would not dare to say that, because this is a difficult job. But I'm going to be leaving him a lot more space to work with this. So let's try. Let's see if my train of thought is working and we can get to a good result. And again, it's pretty old photos, but I think it is a case that is very nice to illustrate what I'm discussing here. So you can see an old surgical template. We don't use those anymore. 3.0 implant diameter in Nobel Active 3.0. That was when it first came out a while ago. And you can see, like I told you, my bone grafting was slightly shy, so I decided to add some more bone substitute in there, just purely for contours, yeah, to have some more aesthetic contours. And as you can see, at there, my first provisionalization I do in here, and now we start to develop tissues. Now, I take an impression, and I ask my lab technician, I want you to send me a bisque train. And I want, I don't want to look so much in the color, I want as well, but I want to look at the dimensions of that bisque train. Okay, so here is the thing. This is close, okay? We got close to the 3 millimeters we were looking for, but we can do better. So what I ask here, we take advantage of the dimensions of mandibular incisors. You know, they're wider in the buccolingual dimension as compared to mesiodistal aspects. So I asked my technician to stack ceramics on the buccal aspect of the tooth in order to recreate that translucency that the denuded roots provide. But if you pay close attention into the interproximal aspect of the crown that I used to restore this case, you can see that it's purely opaque. There was no space for anything other than opaque. And as you can see here, actually the crown is still over-contoured, is still wider than the adjacent centrum at the neck area. But in my eyes, in my hands, this is probably the best I could have done at that time, knowing what I knew back then. Now, going back to the situation that I was explaining at the beginning, and that's a more recent case, we decided that we didn't want to do immediate implant placement. And if I rule out immediate implant placement for bone anatomy reasons, for bone configuration reasons, I automatically rule out early placement. If you cannot place an immediate implant placement because you don't have apical bone to stabilize, actually early placement won't work for you either, because essentially in terms of implant placement, an early placement is exactly the same as an immediate implant placement. A socket just 8 weeks after extraction is pretty much the same as an immediate fresh extraction socket. So in this particular case, what I decide to do is to go in there and do a socket preservation, okay? Extract the tooth, put a bone substitute. In this case, I use a xenograft with collagen membrane, and I don't, because as you saw before, it's a very narrow socket. I do not pretend, and there is very, very little socket to preserve here. I mean, what I'm trying to mostly do by extracting the tooth and doing a socket preservation is to avoid tissue collapse. I do not want all this tissue to collapse down. Then, and at the same time, we go in there and we put a Merlin bridge. You see a transitional temporary adhesive or resin bonded prosthesis, if you will. And as you can see on the bottom right, that is a few weeks after the extraction of the tooth. Then I showed you how before, how we improved or we changed the biotype of all these teeth in the area. We increased the thickness and we do root coverage to make sure we have a more pleasant area aesthetically, and on top of that, like I said, is more resistant to recession and helps us concealing those restorative structures. And at that time, I start planning for the implant placement. A very, very narrow situation again. Decide to go ahead and do a diagnostic wax up. This is a protocol that I don't do today. It's half analog, half digital. I would do it fully digital today. But back in the day, we still have to pass through like you see, a diagnostic wax up analogic that we will turn into surgical template. You can see surgical template in the patient's mouth. The space is so narrow that we cannot even place the implant entirely through this template. We can only do the pilot drill. Yeah, then the rings will be too wide. If we wanted to do the implant placement through the template, the rings will be too wide for that. We will have to use a ringless template, which we use nowadays. As you can see, the implant is a narrow implant, 3x10, which was placed. I expected I was going to have some fenestration in there. Adhesins, sorry, and as you can see, how we regenerate the adhesins again with, as you can see, some autogenous bone harvested locally and some xenograft as well. You can see in this particular case, I decided to submerge the implant. In general, to provisionalize, for me, in my eyes, is in general mostly to preserve tissue. At the initial stages, if I want to build up tissue, I prefer not to provisionalize. I prefer to bulk up tissues and at a later stage provisionalize to shape these tissues that I originally bulked up. And as you can see, how I take advantage here just a few months after the placement of the implant, very nice looking tissues, and I take advantage of the same surgical template I previously fabricated to perform minimally invasive second stage surgery. I just use actually a periodontal probe. And in this particular case, I use a slim abutment, the one designed for Dr. Iñaki Gamborena. And it's a very, very narrow, very extremely narrow healing abutment that actually really does not distort the soft tissues at all. And it really helps obtaining that tissue that we need to make a good looking restoration. Then at that point, I go ahead and make impressions. You can see already that the narrowest impression coping in the catalog of the company I normally work with is wider than the diameter of the root of the central incisor to be restored. So that's already a challenge to start with. In here, we cannot work with a model that represents exactly what we have acquired with impression. We actually had to develop the emergence on the stone cast, as you can see below. Yeah, that's the negative of the impression. See that my technician, in this case, Inge Magne, and a good friend of mine as well, and in my opinion, one of the best technicians in the world, developed this emergence in stone by carving stone in this area, and then based on an ideal shape of the gingiva, she makes the temporary restoration. And that's the temporary restoration as I receive it in the clinic. And as you can see in this case, Inge told me, I'm very sorry, Juan, I really try my best, but central mandibular incisors are very tough. I don't think I can make this restoration narrower in the lingual aspect. And I think that's acceptable. That to me is acceptable, but that is, again, the limitation of this type of situation, particularly in the lingual aspect. So as you can see here, we developed the temporary, we place it in the patient, screw retain temporary whenever I can, outline the critical, the gingival margin, desired gingival margin, and below that line, narrow the emergence of the temporary crown as much as possible to maximize that horizontal availability of tissue that we're going to need in order to reshape the gums with the temporary. Concept by my good friend Ernesto Lee and Oscar Gonzalez, and the concept that I have been using for the last 5 years, and I find it a very, very good concept to manage soft tissues. So the concept is precisely as you see in this slide. It basically assuming that we place implants 3 to 4 millimeters from the predetermined gingival margin, you want to make sure that the critical contour, which is the first millimeter from the gingival margin, is of the same diameter as the crown to be restored, whereas the 2 to 3 millimeters below that critical contour have to be, like I said, about the same diameter as the implant itself, essentially as narrow as possible. As you can see here, as I received the temporary, you can see in the previous slide, the one I was showing you, it's slightly over contoured, if we want to follow that concept. So I have to polish this and reduce diameter, which is what I do here. And we go ahead and place the temporary for a few months. In that particular case, it was almost there for 6 months while shaping tissues. Now, that case was done just right at the time when I was personally starting to use intraoral scanners. And the first surprise I had in here is there was no intraoral scanner, intraoral or scan body available in the market that would actually fit within that space. So I actually had to go back to conventional impressions in this particular case, which I did. Then again, in order for me to customize, we know that we like to transfer the emergence profile we have achieved in our temporary restoration by using the technique developed by Hinz and improved by Iñaki Gamborena again. And in order for me to do that, I had to reduce the copying itself, because otherwise I wasn't able to customize it. You know, it was very tough restoratively. But as you can see here, this is already a 2 years follow-up, and with this I will finish. How with a careful planning, an adequate analyzing, like I said, bony structure, understanding the relationship between the axis of the axis of the understanding that the gingiva is different, understanding that every half a millimeter that we can save will make a difference at the end in the aesthetic result. That would be very important for us. So Omid, thanks. I hope I could shed some light on mandibular incisors and things, and especially open up young minds, open up young minds to realize there is a lot of areas for research in this. and to join us in our research group if anyone has interest. We're always open to bright minds. But Omid, I don't know if you may have any question. That would be a great time for it.
Sure, sure. First of all, I would like to thank you so much for your beautiful presentation on the topic. It's not a compliment. I truly enjoyed every second of it because, as you said, it's one of the areas that is very challenging and we don't often hear about it by different lecturers in platforms around the world. So it was very interesting, and I have to congratulate you because the way that you described it step by step, it was like truly a classroom, and it was full of data and it was crystal clear. And the management of the cases actually that you present is superb because nobody can even guess that which one is tooth and which one is implant in this aesthetically challenging area in the lower anterior. So I have some questions regarding the lower anterior implant placement because the way that you describe it, maybe it seems easy to some people, but in reality, it's not that easy. And you brilliantly presented the importance of available spaces that we have and the way that we need to manage to how to properly place the implant in those limited spaces. And as you said, the article by Marco Esposito in 1993, he also mentioned that the closer that we get the platform of the implant to adjacent teeth, the more risk we have for losing the bone around. And it's like the concept of horizontal biological width formation. So my first question is going to the first case that you presented, the patient that had recessions in lower anteriors, and you decided to place the implant regarding the patient's demand. And the patient asked that, I don't want to touch my other teeth. So I want to know, do you think of like Maryland bridges or resin bonded restorations in lower anterior mandible as an option, as a permanent option for the patients? I'm just asking this because I want to make it clear, should we always go with implant placement in single tooth missing in the lower anterior? Do you find it risky? I'm pretty sure you will find it risky, but if a patient come to you and ask for replacing the missing tooth, I mean, now I'm asking for only one missing tooth. Do you think about Maryland bridges in the area, or you always go with implant placement?
You know, I would have to separate Maryland bridges for me. Conventional Maryland bridges, metal-based resin bonded prosthesis, and you know all the problems in general with change of color because of ions of metal getting inside the tooth. So for me, nowadays it's just not an option. You know, this type of Maryland bridges I would never do. Now I think lithium disilicate and bonding, you know, adhesion has changed a lot. It has changed a lot, and it would be naive not to embrace what it can do for us in certain scenarios. And I repeat, in certain scenarios, you know, low occlusal load, obviously, and one thing that you just mentioned at the beginning when you made this fantastic question is the fact that this patient has periodontal teeth. Yeah. Periodontal teeth means in nature certain degree of mobility. Certain degree of mobility is exactly what you don't want to have in a resin bonded prosthesis connector, you know, and especially if you use materials, because like I said, for me, resin bonded prosthesis makes sense nowadays if you use a prosthesis that is ceramic based, okay? Because you can reduce the amount of lingual prep or palatal prep that you have to do. You can go very thin, you're very not invasive in the teeth, yet if you have any mobility on those teeth, the connector at some point will fracture, yep? So for me, essentially the thing would be precisely that. If I have a patient with simple occlusion, okay, not a heavy protrusive in the central incisor, let's say, periodontally sound teeth, I would not have a problem. I would not have a problem if the patient was to understand that that would not be a solution that will probably be as long lasting as an implant or as predictable as an implant. I would not have a problem doing that and telling the patient, feel confident that we'll stay in there for quite some time. You know, again, my design will change. We know nowadays that resin bonded prostheses are better off with only one wing, you know, instead of two, in particular in this kind of cases. But I would not have a problem. Now, like I said, periodontal patients, absolutely not an option for me. And to me, dentistry is very simple. It always comes down to what I would do to my wife, what I would do to my mother, what I would do to my sister. My mother and my wife don't love going to the dentist. They don't like going to the dentist that much. So they can come a couple times. Instead of having to come every 5 years to replace their resin bonded prosthesis, they're very happy. And I think that answers the question.
And regarding this question, I want to know, because you mentioned the periodontal disease patients and the mobility of adjacent teeth. Do you think that the mobility of adjacent teeth can have an influence on the survival or success of the implant that you're placing between them? That's number one. And part two, can we say that bonding restorations can help like splitting those teeth together and minimize the movement?
I mean, of course. I mean, the first question, is the fact of having periodontal teeth gonna affect your implant success or survival over time?
Because they're
so to me, in my eyes, we're talking about periodontal disease, periodontal disease that is treated. If a patient is treated and comes to regular follow-ups, the thing that worries me the most is actually the occlusion. You know, occlusion in periodontal patients, even if they are patients that regularly like to come to do their periodontal maintenance, there is sometimes certain mobility on their teeth, and you have to make sure that you keep your implant protected occlusion. You know, the one described by Mish a long time ago. You keep that implant protected occlusion the way you set it up originally. So in this particular cases, I always pay extra attention to the occlusion. You know, now if the periodontal condition of the patient is going to affect directly my implant survival, literature is quite clear. It's because the patient hasn't been periodontally correctly treated, or the patient is not following their protocols. In my eyes, and again, I have to keep in mind that my follow-ups, because I'm still very young, my experience is not very long, but in my eyes, and I have cases now with 10 years of experience, that or follow-up, if a patient is periodontally treated, I don't see a problem with the implants in general. Now we have to remember that patients psychologically, and we as people, we go through up and downs through life, and it's true, it's a fact. Whenever a patient, periodontal patient, has a hard time or actually sometimes neglect themselves slightly, impacts the implant probably faster than it impacts their own teeth. The breakdown, the periodontal breakdown, and this is something that has been observed in literature too, is actually more pronounced around the implants when the situation is not stable. Now, in relation to using a Maryland as a splint, as a periodontal splint, which was your second question, and if I think it will help stabilize the situation, the problem I have with that is, again, the size of the connectors. You know, first of all, I'm not a big believer on zirconia adhesion. You know, it's not, and not because of the adhesion. You know, there is proof that you can adhere zirconia, especially certain in vitro studies, but the problem with zirconia is the size of the connectors. We know that since a long time ago. If you want to make a splint with zirconia at the back, you need very long connectors. In a periodontal patient, that essentially means difficulty in hygiene, which is the key for the prognosis of a periodontal patient. So for me, it's not an option. I much rather do a single unit implant and splint with a small wire and a small composite bondings that actually really do not difficult the hygiene of that patient. Now, some people may tell me, well, you're talking about zirconia. Why don't you talk about, let's say, lithium disilicate? You know, yes, you can do lithium disilicate, but at the end of the day, again, you will be able to make smaller connectors and smaller prostheses, but then again, the mechanical resistance won't be the same. And I have tried a few times with not the best results. And in my opinion, at the end, no matter what, you end up making difficult hygiene for the patient. So in my opinion, I'd rather go with a single implant and do a conventional splinting. Yeah.
Great, great. I have to say I also agree with you, but I just want to ask this question because it comes to some people's and practitioners' mind that maybe that option, maybe this option. So I just wanted to open it up to discuss a little bit about it. And what about your idea on one, I mean, like one piece implant? Because sometimes we have very limited spaces, and if we get rid of the connections of abutments to the platform of the implant, we can, as you presented, how we can provide more space and minimize the bone loss or bone resorption or remodeling adjacent. So do you think that one piece implants can be a good option in lower anterior zone, or do you
I
think
think so.
limitations?
I think so, Omid. When I first started in Loma Linda, a good friend of mine, Francisco Leva from Mexico, resident in the implant program as well, was running research specifically looking at the success, where they placed it in multiple areas, but mostly was a mandibular incisor Zimmer implant. At that time, it was a 3.0 one-piece implant. And we had the chance to look at results of these implants, and they work well. And from a restorative standpoint, you're right, and it's very often made our life easier. The issue essentially with one-piece implants in the mandibular region is related to what I was telling you, that discrepancy between the long axis of the tooth that we see in some cases and the long axis of the bone. A one-piece implant in an ideal world with a lot of bone and a lot of in very favorable situations is fantastic. The problem with one-piece implants is the versatility. They're not versatile. I mean, if your implant is if the position of the implant is not ideal, there is no way in the world you can correct that prosthetically. Yeah. So my answer is yes. I think there is room for one-piece implants. I think there is a lot of scenarios where one-piece implants should actually be considered when we normally don't even think about them, and we should think about them because they can solve a lot of situations. Now, is it a type of implant that will solve all mandibular incisor situations or maxillary lateral incisors? I think so. I don't think so.
Yeah, and Juan, what about co-axis implants? Because in mandible, as you said, we have a lot of inclination to the buccal. So what about going with co-axis implants to go to the direction of the bone, but place our abutments parallel to the adjacent teeth? Any experience on that?
I think the idea, I have investigated a bit on coaxis configurations, and I find them quite interesting. I think there is more. Okay, I want to come out honest and politically correct at the same time, but I think there is a lot of future for these philosophies. But there's more future than present for me right now. They have to be developed a lot. The diameters of the prosthetic component have to be reduced significantly to deal with these situations. But if we can manage to do that, I think the future may be there. I think the future may be there, you know, to be able to have the discrepancies in the way we screw into the implant and the position of the implant. I think the idea is nice. And one of the projects we have with our research group, and you guys all will see the research group being announced soon. And actually we'll take the advantage to announce it now. It's called Indent Research, and it's going to be with you may know him, Israel Paterman, Implants DC. If you look in Instagram, Matthew Finn, or Finodontics. If you look in Instagram, then myself, Ferran Llansana here from Spain, one of the best prosthodontists of the country. And then Guillem Balsa, which is a researcher from University of Swansea, a specialist in bone metabolism. And one of our lines of research is precisely the one you described, and I have a lot of interest in it, Omid. So I hope next year when we talk again, I have the chance to tell you a bit more about coaxis, because like I said, I think it's interesting.
Great, great. And if I get it right, I think with your concept and with your precision in your surgery, if you lose two central incisors in the mandible, do you again prefer to place two implants, or you prefer to go with one cantilever?
I think I will have to say that on a case basis. Okay, I have treated one case where I placed 2 Jensen implants. But then I have to say, I mean, the mandibular incisors that that patient had were abnormally wide. I mean,
Yeah.
if you ask me,
It was
as a general rule, 2 central incisors, what would you do? I would place 1 and cantilever and now 2 implants. Will I do it? Yes, probably in my next 30 years of career, I'm going to find another case where I can do 2 implants. But is it something that you should recommend to people to do it regularly? I don't think so. I don't think so.
Yeah. And Juan, my final question, because I'm also a great fan of Inaki Gambaran and the way that he does things, it's amazing. But speaking of narrow abutments, as far as I know, it's not available for all implant companies. So if I remember right, it's available mostly for Nobel Biocare, if I'm right. So do you think it's possible to, for example, ask companies to make the same line for their implants? Or do you think we have another easy options for going in that path? Because I'm not sure if it's possible to make that slim abutments as a customized abutment by different companies. So it should be original and be designed exactly at first hand with that design. So do you think it's possible, or do you have any other options regarding that? Because if I'm not a user of that specific brand or company, what should be my move? Yeah.
I think essentially you cannot use a regular abutment because precisely the idea of the slim abutments is not to have the access hole and get rid of that access hole to generate or to reduce the amount of metal, the bulk of metal that you have to the maximum. But essentially, if you think about it, this is just a regular healing abutment that has been reduced horizontally to the maximum degree to make it as thin as possible. And actually, it is as thin as the head of the screwdriver. What is key, and again, I would like to hear the thoughts of Dr. Iñaki Gambarena on this, but at least in my eyes, what is key is that the base of the abutment, the design at the base of the abutment, because you have to keep in mind, if you think about histology, right? If you think about histology of the peri-implant area, the first millimeter, let's say 1.2, 1.4, depending on the actors the authors you look at, is that area where you get the connective tissue attachment. That's the area where it actually protects the seal around the implant. If you have a slim abutment that is extremely narrow up, but it's very wide at the bottom, by the time you try to remove it, you're gonna tear completely the connective tissue area. Now, the good thing of the abutment designed by Dr. Gambarena is precisely that, is the fact that, yes, you feel resistance while you remove it, but not as much as you would expect. It's actually a clean removal. The first time I actually used it, and when I looked at it, I thought, well, this concept, if not properly designed, could actually be very detrimental. But then you start using it and you realize that it's really well designed. And what I would try, if you were not a user of this system, is actually just that. You get a very, very narrow healing abutment and just reduce it with metal burrs. So at the base, at the connection level, you make it pretty much concave to the point that is almost like a wire emerging out, but then you have to have sufficient resistance at the area where you reduce, because what could be a serious problem is by the time you try to remove it, it fractures at the weaker area. And that's something that concerned me as well at the beginning. I have never seen. So for me, I have to say, and it's really not, I do speak for the, and Omid, I do speak for the manufacturer that fabricates these implants, is my main sponsor nowadays. But I have to say, without any commercial interest, it's a very well-designed product. And it has really, really changed the way that I do things nowadays, especially, of course, when it gets to a dental size. Completely. It has really, really changed the dynamics of what I do today.
Well, I have to say, Juan, I totally enjoyed the presentation, and thank you so much again for your time. And I know it's weekend there, so thank you for joining me in the weekend. And Hope to see you very soon in beautiful Spain or maybe anywhere else in the world. It was a pleasure for me having you. And I have to say again, I said it at the beginning, before even seeing your lecture, and I said it at the end, I truly enjoyed every second of it. Very precise, very beautiful, very going into the detail and comprehensive. So thank you so much. It was a great discussion and great evening here in Tehran with you, and hope all the audience enjoy the presentation, and hats off, my friend.
Thank you very, very much, Omid. I mean, like I told you, an absolute honor to be amongst the group of giants that you managed to get together. Again, I hope everyone enjoyed this lecture. We have a lot of courses here in Spain. These lectures, obviously, because of the format is very short. I didn't want to go too long into this. It's been an absolute pleasure. And again, I hope to see you soon in person, which will mean that everything is going back to normality. And for most of all, stay safe and keep having this amazing energy you have, Omid. Good job.
Thank you so much, my friend. Take care and bye-bye. God bless you.
Take care. Thank you. Thank you, everyone. Bye-bye.